You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 20th, 2020. This week, again, it's coronavirus and COVID-19, but I'll have some cardiology mixed in. It's only been a week, but it feels like a year. Yesterday brought news of 4,000 new coronavirus cases in the U.S. Overall, the numbers were even more stunning. 8 days ago, we had 1,700 cases in the U.S. Yesterday, there were 12,000. Of course, this is what exponential growth looks like. My city of Louisville is not a hotspot, but we do have cases. And when you have a few cases, you know more are coming. So my hospital, like yours, is planning. Medical assistants are being reassigned, some to cleaning duties, others to nursing assistants. Early in the week, we were screening visitors at our hospital. Now we are essentially banning visitors. Elective cases are postponed, the census is down, the hall's quiet, and the room's open and ready. Now look, I try to limit cliche when I write, but here goes. Last week, there were reports of a storm brewing offshore. The skies were clear. The elective cases went on as normal. It was like a clear day. But this week, we can feel the winds of the coming storm. I feel as if I am aging every day. A cardiologist friend of mine likened his experience in his clinic to a slow-motion car wreck. The office is a bit surreal. There are two types of people, those that are on social media who, like me, seem to age every day, and then there's the blithely unaware. The latter group enhance the anxiety of the former. Another emotional moment. My phone rang yesterday. It was from WhatsApp, a friend and colleague from thousands of miles away. His country, like ours, on the precipice. The reason for the call? Just to talk. Now, Medscape has a useful COVID-19 section set up. This includes a fantastic piece on how French centers are getting ready for the surge. There are some specifics this week to talk about. The first issue is the crisis in personal protective equipment, or PPE. There's a shortage brewing, and I wrote a column on that, and the column is up today. The images of how the caregivers in China protect themselves versus what we are doing here is shocking. That said, the majority of healthcare workers in China were infected, even with their protection. So if we don't do something about the PPE shortage, we're going to have serious problems. Not only will healthcare workers get sick and some die, but without proper PPE, we'll become super spreaders of the disease. What's more, if healthcare workers are sick, who will care for the surge of patients? I think the little bit of good news, at least what I heard from the press conference yesterday, is that it seems like the government is taking action to get us more masks, primarily from industry. There's also been some talk about treatment, specifically, first, hydroxychloroquine. Now, this comes from a couple of tiny studies. One was a French case series of 26 patients in Marseille that received the drug hydroxychloroquine versus 16 control patients. The endpoint of this small study was viral load. In addition, among the hydroxychloroquine-treated patients, 6 received azithromycin to prevent bacterial superinfection. Now, you may have seen these graphs on social media. The drug hydroxychloroquine reduced viral load significantly more than controls, and the small group with added azithromycin cleared the virus even faster. A previous study from China showed that in vitro hydroxychloroquine did better than chloroquine for inhibition of coronavirus activity. That is all I know of, a non-randomized small study and an in vitro study. President Trump lauded these results, and he gave false hope in yesterday's press conference. Fortunately, FDA Commissioner Stephen Hahn immediately walked these false hopes back and said, yes, obviously, this small French study is an important hypothesis-generating study, but we need to do proper controlled trials. Now, the good news about COVID-19 is that given its severity, it will be easy to conduct a pragmatic RCT, both using viral load as an endpoint, but more crucially, we need the RCT with clinical endpoints. Recall that the viremia alone is not the only way this disease kills. It can also kill by inducing a hyperimmune response that runs amok. And speaking of RCTs, New England Journal published a disappointing trial, a lopinavir-ritonavir in COVID-19. This trial of about 200 patients found that mortality at 28 days was similar in the active arm versus the standard care arm. There was a 19.2% versus 25% difference that did not reach statistical significance and had very wide confidence intervals. Now, I want to be careful here because the new vernacular is not to call this a negative trial, but to say results do not provide enough evidence to reject a null hypothesis of no effect. It could be that a larger trial might detect some benefit. The next piece of news is on a drug called remdesivir. FDA Director Hahn announced that the NIH began an RCT for the treatment of COVID-19 patients with this investigational antiviral drug. And on the FDA site, they write that about 250 patients have been granted compassionate use already, and Hahn pointed out that this will allow observational data collection. But of course, observational data collection is not enough. The lopinavir RCT shows the importance of randomization. To know if this drug or any drug works, you need a control group and randomization. Again, a pragmatic RCT will not take long to do, and we should know in a few weeks or months if any drug works. Now, there's also talk about convalescent plasma. This is a super interesting approach in which people who recover and are virus-free can donate blood, and the plasma of this antibody-rich blood can then be given to ill patients. This, I have read, was used in the 1918 flu pandemic, but there's not much data. Again, very interesting concept. Now, specifically in cardiology, you've probably seen the studies showing that a not so small prevalence of cardiac involvement with COVID-19. There's LV dysfunction, ventricular arrhythmias, cardiogenic shock, and these can be proximate causes of death, in fact. I've also seen reports of COVID-19 myocarditis, which is important because myocarditis can be a STEMI mimic. So this means transferring patients to the cath lab and exposing lots of people. Alternatively, there's also been talk of using thrombolytic agents in an effort to reduce exposure of cath labs for STEMI care. Of course, we're going to have to be careful about giving lytic agents to patients with myocarditis or other coagulation problems because that'll be a disaster. Some of my colleagues in electrophysiology have speculated on the use of early mechanical support in patients with COVID-19 induced shock and also the use of IV amiodarone for prophylaxis. Both of these are plausible ideas, and I really would like to think about them more before commenting. Next week, I'll have studied more on the acute cardiac effects and have more comments. I'll also try to provide more clarity on biomarkers in COVID-19. Stay tuned, please. Finally, in closing, I want to speak about the upcoming ACC and HRS meetings. HRS has not yet postponed, but this is an absolute certainty given that May is likely to be close to the peak of the surge of coronavirus. ACC will attempt to have some sort of virtual meeting in the coming weeks. To both societies, I would encourage you to just scrub attempts at these virtual meetings. Not because it is not possible, of course we could do it, but because literally no one cares at this point. There are models that have us in social isolation for up to a year or more. And soon there will be surges of sick patients to care for, and sadly there'll be stories of colleagues who are dying from COVID-19. how can we garner any interest in anything but the biggest trials? And even big cardiology trials, even those will seem small in this year of COVID-19. Until next week, I want to say to you, my friends and colleagues, please, I wish for your safety and I wish for the best of luck to all of you. And as always, I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.